إذا العنوان المحاضرة title Respiratory Distress Syndrome أو داء الأغشية الهلامية. Historically we used to call it hyaline membranous disease (HMD), and now some people call it surfactant deficiency disease. They're all talking about the same thing. طبعا سيتعرف عن حالي أنا الدكتور ميسان شعار، استشاري بالأمراض الخدج نيوناتولوجي في الرياض من الحاصل على البورد الأمريكي. طيب, so surfactant deficiency disease or respiratory distress syndrome, as the name implies, is primarily related to lack of surfactant. That results in high alveolar surface tension and lung collapse. Why is it deficient? Is because it's not produced to start with due to prematurity, which is the most common factor. Sometimes it is due to inactivation, due to pneumonia or meconium aspiration. And rarely it is a genetic absence or malfunction of the surfactant. For the last one, it's seen mostly in full-term infants. Probably the same for meconium and pneumonia, but the most common one is the premature presentation in prematurity due to a decreased production. Clinical presentation. So the respiratory distress presenting shortly after birth in a baby who is born premature. This is associated with typical clinical, laboratory, and radiologic findings. In the picture, you see twins with the chest retractions, the so-called seesaw breathing. Yani during inspiration, this instead of normally the abdomen is big, it's small, and vice versa. So the seesaw, this is associated with use of accessory muscles and grunting, small lung volume, the so-called ground glass appearance, and the blood gas reflecting respiratory failure. Discussing the production of the surfactant, the alveoli has the lining cell, which is the type 1 cell, the thin, long one, and then you have the type 2 cell. Type 2 cell is the one that produces the surfactant. If we take type 2 cell and make it bigger here, it is produced in the cell and then in the form of so-called lamellar bodies. It's like a ball of wool, زي الصوف. It goes to the outside layer and unwinds, تفتح كده و form a surfactant film, okay, in the hypophase, and that by itself lowers the surface tension. Also, it's dynamic surfactant activity. So during exhalation, where the risk of collapse is high, there is a linear lining of the active substance of the surfactant, the DPPC. It expels the water and then it lines the alveoli, preventing it from collapsing. During the inhalation, then the pressure surface tension can be high because there is increased pressure of the air. So there is some kind of lucency with water in between the surfactant molecules. When discussing surfactant deficiency, we talk about the Laplace law, قانون لابلاس درسناه في المدرسة. So this is the formula. The pressure is related to twice the surface tension, and inverted correlation with the radius. If there is bigger radius, there is less pressure needed to inflate a balloon or any molecules of any hole. So if there is, for this, because the radius is twice this radius, so you need half the pressure to inflate this alveoli or alveolus. The pressure is though coming to the lungs is the same. Yani the pressure that the body generates is the same. Now it depends on the alveoli, how big or small that related where the pressure goes. So the pressure if the radius, I'm sorry, is high, as in this case, the pressure would differentiate going to this alveolus versus this, because it requires half the pressure to inflate. Whereas if there is surfactant, here the point of surfactant, the surfactant will lower the surface tension into half. So with this, with lowering the surface tension with the same pressure, both alveoli are inflated. Without surfactant, only the bigger alveoli will be inflated and the small one will be collapsed. And eventually we'll have big alveoli that is lined with the hyaline membranes and collapsed alveoli for the remaining of the lungs. The hyaline membranes on the pathology, and where the name came, originally diagnosed based on pathologic findings. So the edema, the cells, and the proteinaceous exudates, they all form this lining of hyaline membranes that you see easily on the pathology slide. So what will happen in terms of pathophysiology? There is reduced lung compliance. So you need more pressure to achieve the same volume. In the normal lung, there's less pressure needed to inflate the lung, and it's easily inflated. And during exhalation, there is no complete collapse. The lung will remain somewhat inflated. With the decreased compliance, you need much more pressure to inflate to a range that is less than the normal lung. This is a classical graph, you see it with the RDS. So more pressure is needed to achieve the same volume. Also, there is reduced functional residual capacity. There is so-called VQ mismatch. So there are areas in the lungs that have blood going to them, but there is no air. There is no air exchange. So that the blood remains deoxygenated, and that leads to so-called right to left shunts and pulmonary hypertension, PPHN. So what is surfactant? 90% is lipids and phospholipids, and then about 8 to 10% proteins. The active substance in the surfactant is called lecithin, or sometimes called dipalmotyl phosphatidylcholine, or saturated phosphatidylcholine. All relate to the same thing, the active substance of the surfactants. And then there are additional substances to facilitate the function of the surfactant. But then there are 4 proteins. It's called surfactant protein A, B, C, D. There's a lot of research about the function of these 4 proteins. But what we know is that surfactant protein B is essential for the function of the lecithin. C, when it is deficient, it can lead to like chronic lung disease. A and D are not necessary. They are supportive to the function of the lecithin. The science of RDS and the surfactant has been really activated by the death of the son of the John Kennedy, the American president, in 1963. In 1963, he had a child, a boy, 34 weeks and 5 days, was born with respiratory distress. They gave him oxygen. They moved him to a bigger hospital. Baby SPED to Boston. So a lot of care, a lot of attention. And despite everything, this baby died at 39 hours of life. At that time, what was available is to give too much oxygen, hyperbaric even oxygen. You give bicarbonate, that's all. So eventually he died from RDS. And that kind of gave the push for the research of the surfactant and RDS treatment. Over the years, the mortality rate, this is between 1974 and 1997, and this is a group of smaller babies, 1750 to 1250 grams birth weight. As you see, there is improvement, significant improvement in terms of survival. So starting around 60–70% in the end of the last century, more like less than 5%. So what happened during this era? So in the 1940s, oxygen was discovered, but oxygen would not treat RDS by itself. And then in the 70s, we have the mechanical ventilations, and then the CPAP came in the early 70s, and then ventilators that has PEEP in it, the positive end expiratory pressure, that in the late 70s, and that by itself, before the administration of surfactant, has resulted in significant decrease in death from RDS. Surfactant came around 1990, and then 4 years later came the antenatal use of corticosteroids. These two factors certainly made a great impact on the treatment and prevention of RDS, but in reality, the improvement even happened before that with the CPAP and advanced ventilators. Now, keep in mind that yes, the mortality rate is less at times when more premature babies are surviving now. So early on, we're talking about premature babies in the 30s, now in the 20s, yet they are surviving. So this is mortality rate from RDS. It's becoming less. Mortality from other reasons. So medicine has improved in terms of other factors, and this is the total mortality rate. Just to remind you, for those babies who are born early, like in the 20s or even early 30s, 30 weeks gestation, the lung by itself is not a normal lung. We're talking about lung not only deficient in surfactant, but lung that is not formed yet, not normal simply. So we have the embryonic phase, so-called pseudoglandular, canalicular, saccular, and alveolar. So the alveoli, which is the normal mature lung, is generated around 36, some people say 34 to 36 weeks of gestation. The saccular phase, yes, it can function with the air exchange, but it is not as advanced as the alveoli. So the more premature the baby is, we're talking about surfactant deficiency plus immaturity of the lungs, which is a challenge. What happens to the lungs that are deficient of surfactant? Lungs become deflated and they have so-called liver consistency. They do not float in water. Normal lungs, they do not sink, they float in water. When it is RDS and collapses, they don't float. There is atelectasis of terminal sacs. There is necrosis of epithelial cells and edema that happens within 2 hours. The hyaline membranes lining the extended respiratory bronchioles, and these containing fibrin and cellular products, these are produced by around 10 hours, if not treated, we're talking. You don't see the tubular myelin or lamellar bodies. Around 24 hours, if the baby is to survive, repair starts with macrophages in the airway. 48 hours, regeneration of epithelium. 3 to 4 days, edema is mobilized, the irises occur, and at 7 days, the hyaline membranes are disappeared. We don't see that in the units that has treatment, whether it's CPAP or surfactant. This is another picture for the hyaline membranes. What is the incidence of RDS? Now, for units that don't have ventilators and don't have surfactants, certainly the challenge is to make this group survive. And the incidence is, yes, it is low compared to more premature, but there are much more babies born in this category. So the number of babies in this category is so high that makes it significant. You can say around 30 weeks gestation, about half of them will have respiratory distress syndrome. Now the challenge is to define the RDS in the extremely premature infants, because they are born with immature lungs and they will have respiratory distress. So many will define RDS as the need for oxygen above 30 or 40%. So the diagnosis is really not straightforward. Now there are confounders of the diagnosis of RDS. Also depend of antenatal steroids, if there is any choriomyelitis or induced lung maturation. Keep in mind other factors in addition to RDS, like TTN, pulmonary hypoplasia, and others. Clinically, the symptoms present shortly after birth.
tachypnea, nasal flaring, chest retractions, compliant rib cage, the so-called CISO. So expiratory grunting, cyanosis, high oxygen demand. Some babies will have apnea. The babies are more premature, simply would have apnea. There's decreased air entry, edema, metabolic acidosis, decreased urine output, and IVH in the old time where they would give a lot of bicarb, a lot of investigative treatments. This course will be to death or improvement in 3 to 5 days, as we talked about. Now, there are cases of late presentation, okay, which is unusual, not the classical, and you need to think of other etiologies. And late presentation is probably due to borderline amount of surfactant that has been consumed. Certainly, the symptoms are more obscured in extremely premature infants, and they are altered if surfactant or CPAP or ventilation are applied early. What makes RDS a higher risk? The most common factor certainly is maternal diabetes. Diabetes is really a strong risk factor for the RDS, especially if it is not controlled during pregnancy. Multiple pregnancies, malnutrition, acute hemorrhage, and finally familial. Perinatal factors include prematurity, perinatal asphyxia, C-section without labor, second-born twin, males more likely, and race. In the US, for example, it's more likely to see RDS in the white people than the black people. Decreased risk of RDS if the steroids were given. If there is prolonged rupture of membranes, chorioamnitis, yes, there are other problems with this, but it seems to be less RDS. If there is subacute placental abruption, females, black race, maternal smoking, hypertension, maybe IGR, these, like overall, anything that put baby at stress that probably produces internal steroids will make RDS less, though it can cause other problems. On the X-ray, as you see, the classic, what we call ground glass appearance with air bronchogram, decreased lung volume. With the severe RDS, you may not even see the lungs, you just see white out lung. It's a little complex slide, but I will summarize it. So basically, we have the two factors, surfactant deficiency and structural lung immaturity. This will lead to atelectasis, VQ mismatch, hypoventilation, hypoxemia, hypercarbia, and that can have dual hit, respiratory metabolic acidosis, pulmonary vasoconstriction, impaired endothelial and epithelial integrity, proteinaceous oxidate RDS. On the other hand, it can cause high inspired O2 and barotrauma that lead to accumulation of oxidants, inflammatory cells, cytokine release, free radicals, and lung injury that will lead to chronic neonatal lung disease, or what we call it PPD. So the disease itself can cause problems, and the treatment of the disease also has its own complications that lead to chronic lung disease. Keep in mind the differential diagnosis, transient tachypnea of the newborn, pneumonia, pneumothorax, meconium aspiration, congenital malformations, congenital heart disease, and congenital diaphragmatic hernia. طبعا they can have more than one problem. There could be RDS plus pneumonia, RDS plus TTN or pneumothorax, but these can make the situation worse. So how do you treat RDS? We have the general care of resuscitation, vital signs, treat other problems like temperature instability, blood sugar, blood gases, give enough oxygen, the nutrition, avoid excessive fluids, and avoid excessive oxygen also. Treat associated diseases. CPAP is a main treatment for RDS. We'll talk about it. Try to keep blood gases in this range. And finally, surfactant replacement with or without mechanical ventilation. And that can be as a primary mode or as a rescue mode, meaning treat before symptoms or as symptoms get worse. And finally, monitor and treat complications. We'll be elaborating on some of these.
CPAP can be a lecture by itself, continuous positive airway pressure. This is so-called Hudson bubble CPAP, but the baby has to be breathing. Keep in mind that CPAP is not good for baby who doesn't breathe at all. So CPAP is basically giving heated, humidified air to the baby. And when the baby wants to exhale, there is resistance, in this case, water seal. So that keeps the air and the pressure in the lung and prevents collapses. So the effects of CPAP increase mean airway pressure and functional residual capacity that prevents alveolar collapse, decrease the VQ mismatch and improves compliance, reduces inspiratory resistance by dilating the airways, prevents pharyngeal wall collapse and obstructive apnea, stabilizes the chest wall, counteracts the paradoxical movements, regulates the respiratory rate, diminishes the edema, and finally it conserves the surfactant and probably augments PDA closure, not for sure. So when the baby is born, premature baby that has spontaneous breath, you can apply the CPAP right away. If the baby is below 32 weeks, it's good to apply the plastic bag and the hat. And if you have a pulse ox in the right hand, this is ideal. So in the labor ward, if the baby is not breathing, you have to do some passive pressure ventilation and consider giving surfactant. If there is minimal respiratory effort, you can try with the CPAP or gentle PPV. If the baby breathes, CPAP. If the baby fails, try PPV again, try CPAP. If he fails, eventually you have to do intubation and surfactant. If the baby is vigorous, you can either observe or start with CPAP with the close observation. So apply CPAP as early as possible in the labor ward, somewhere 5 to 6 or 7 centimeter water. Do proper CPAP maintenance and monitor for failure. Infants who improve quickly need to have their CPAP weaned to avoid pneumothorax. So again, you have to increase or decrease according to the need. If you don't decrease the CPAP, you're risking the pneumothorax. And monitor for CPAP failure and intervene early. Do not let the failure go for a long time. So CPAP maintenance, observe the baby's vital signs, oxygenation activity, check CPAP system, inspired gas temperature, air bubbling, empty condensed water in the circuit. Check CPAP prongs position. This is important. Keeps CPAP away from the septum. So septum injury is a common complication of CPAP. You can use the cap to fix the CPAP, suction as needed. Okay, and you can change the baby's position and change CPAP circuit once a week is probably a good idea. And there are some sizes for each weight. Use different size of CPAP. You need to avoid nasal obstruction from secretions. Some babies will have the gastric distension from swallowed air. Again, nasal septum or necrosis is something you need to avoid. And avoid the dry air or improper size CPAP prongs. Finally, air leak is a complication you need to avoid. In the unit, if you have a baby on CPAP, if there is any apnea or high FiO2 more than 40%, intubate and administer surfactants. If there is sustained respiratory effort and FiO2 below 40%, keep the CPAP. You can do blood gases. And depends on the gas. If it is pH below 7.20, FiO2 more than 40%, intubate. If it is proper numbers, more than 7.20, less than 40% oxygen, just observe. After you intubate and give surfactants, you need to follow up with gas and X-ray, and then it depends. If the oxygen is more than 30%, consider additional surfactant if the baby is still intubated. If the baby has normal gases, extubate quickly to CPAP. And in a premature infant, give caffeine or theophylline. This is a study in South Africa. They don't have ventilators. So they had 309 infants between 0.5 to 1 kilos, more than at least or more than 25 weeks gestation.
So these babies were divided into two groups, 2/3 only CPAP, 1/3 they were given surfactant and followed by CPAP. So they're telling us the group of CPAP, 80% of them survived to discharge. The group with the CPAP and surfactant, 63% survived to discharge. Certainly these are the sicker babies. So the message from this study is that CPAP can save a lot of babies, even as premature as 25 weeks gestation, but needs to be done really properly. Another mode of respiratory support is called Vapo-therm, which is heated, humidified flow. The advantage, it causes less nasal injury and easier to place the infant in prone position. However, it seemed to be not as effective as CPAP. Maybe good for weaning of the CPAP or for cases who are not that severe. There are many studies comparing this with CPAP, but it seemed to be CPAP superior to this. Mechanical ventilation. So some people would recommend so-called insure, intubate, give surfactant, and extubate. This used to be more common before. Nowadays, people lean more towards only CPAP. However, some babies need to be really ventilated, and this should be a primary mode in extremely premature infants. Now, where do you do the cutoff limit? In our unit here, if the baby is 27 weeks gestation or less, we intubate almost all of these babies. In some hospitals in the West, they intubate only like the 23-weeker, 24, 23, but 25, 26, they do CPAP also. After intubation, consider the volume targeted ventilation. If the machine is advanced and has the controlled volume, this is preferred. Monitor for ET tube obstruction due to surfactant or secretions. In case of high mean air pressure or oxygen, baby needs more surfactant doses, and consider sedation. After improvements of lung mechanics and perfusion, wean quickly and extubate to CPAP after fearfully no caffeine. Now keep in mind the complications as well. This is a study done in 2011. Took 3 groups of infants between 26 and 29 weeks gestation. They gathered 648 infants in 27 centers. So the first group, they give them, they intubated them and gave them surfactant right away. And they maintained on the ventilation until they extubated later. Second group, they did so-called the insure, intubated, gave surfactant, and extubated to CPAP. Third group, only CPAP. There's no intubation, there's no surfactant, unless the baby fails the CPAP. So the outcome is death or PPD. Now, any studies about RDS, usually they look at death or PPD. They'll either die or they have chronic lung disease. So this outcome was not statistically significant in the 3 groups. However, the advantage of this study is that in the CPAP group, 48% did not need intubation and 54% did not need surfactant. So you can avoid intubation in big number of babies. Putting these 4 major studies together, okay, each one of them had an arm for the CPAP. So these studies, they all tell us that there's a high rate of CPAP only success. So the ones who failed CPAP and needed surfactant, 30%, 38, 67, 45. So about similar to the other study, somewhere around 50% of those on CPAP only without surfactant did not need intubation or surfactant. This is another study, also implies 4 trials. Again, this study showed that babies on CPAP, they had less combined outcome of death or PPD. So not only you are avoiding intubation, in this study they're showing that you are having better outcome with CPAP versus intubation. So if you take the death or PPD, putting the studies together, you have certainly improved outcome. If it doesn't touch the number one, the middle line,
that means it's significant. If you take death or PPD alone, it is not significant. But what matters is combination. But this study has some weaknesses, and it seemed to be that the ones on CPAP had a little bit, they were less sick than the other groups. Speaking about surfactant treatment, it was made commercially available in 1990. It is historically administered through the ET tube, but recently we know that we have less invasive administration. We'll talk about it later. So we have two types of surfactants, which is the natural surfactant, taken from animals. This is the classic form of treatment. We have many brands. The common one is Surfanta, 4 ml per kg every 6 hours, maximum 4 doses. We have Infasurf, we have Curasurf, we have Bliss, we have other substances, other brand names. The synthetic one, the one made in the lab, it is not as effective. Why? Because they could not add the protein B we talked about before. The so-called Exosurf, it came early at the era of Surfanta, but it failed and removed from the market because it did not show the effect in comparison with Surfanta. Recently, there is something called lucinactant. It has a protein B, but it didn't make it to the market. So there is no synthetic surfactant available commercially. Some now would talk about so-called LISA, less invasive surfactant. So you put the laryngoscope, okay, you take this forceps, you put the tube, okay, nasogastric tube or tube administration to the airway. So you just put the laryngoscope, okay, and give the surfactant gradually with the CPAP on the baby. So by doing this, you don't have to give too much pressure to the lungs. You are avoiding the lung damage that we talked about when talking about chronic lung disease or PPD. So here, gently, the surfactant is administered gently to the lung and gradually. And there's a lot of research. This is something relatively new. So a lot of research about this. This study, for example, 60 infants, more than 32 weeks gestation. It showed that that babies required less intubation if they were given surfactant this way. Though eventually in this study at 48 hours of life, it's comparable rate of intubation. One more meta-analysis comparing in fact 6 studies, but they have 4 lined here. This one showed that babies who were who received the LISA, the less invasive, they had less need for mechanical ventilation at 72 hours of life. And then when putting the studies together here, it showed less composite outcome of death or PPD. So that's what matters. Does this form of surfactant administration, does it really lower morbidity, lower the long-term complications? But there is weakness, in fact, with this study. It's not time to talk about it. How do you prevent RDS from happening? Certainly, if you can prevent prematurity, which is not easy. If you can delay delivery by giving medications, bed rest to the mom, so that you give time for antenatal steroids to work. Okay, if you give beta blockers or actually beta agonists, so to delay the delivery. So there are multiple medications they give to the mother to kind of delay the labor and give time for the steroids. You can check lung maturity before a planned C-section. Let's say a mother had many C-sections and there is fear of uterine rupture, they want to deliver early, or if the mom, let's say, had preeclampsia or other reasons to do some kind of elective cesarean delivery, and these mothers, you can check the maturity, lung maturity. There are different ways. The famous and the old one is lecithin to sphingomyelin ratio, but there are other tests to do. Giving antenatal corticosteroids. Now, historically, this is given to threatened delivery between 24 to 34 weeks gestation. This is all agreed upon. But then more recent studies showing, which we use in our hospital, that if the gestation is 34 to 37 weeks, that it's better to give steroids to also prevent RDS in this group of babies. And finally, if you give surfactant before any symptoms, okay, so maybe the more premature infants, if you decide to give surfactant, just you may want to consider giving it before symptoms in the labor room after stabilization. This is a meta-analysis, a group of studies showing the effect, the advantage of the antenatal steroids. So it lowers the incidence of RDS in all infants. Okay, it lowers neonatal death. It lowers intraventricular hemorrhage even. But for the necrotizing enterocolitis, it's probably not significant. So certainly it has a lot of significant advantages. There are two common medications to give, either betamethasone, 2 doses, 12.5 milligrams IM every 24 hours, or dexamethasone, 4 doses, 6 milligram IM to 12 hours. Oral dexamethasone, we don't know how effective it is, okay, but if it is the only thing available, you can consider giving. But after the second dose, you need to wait 12 to 24 hours to really ensure that maximum effect of steroids. Now, if you give the mom steroids, but she does not deliver, let's say she comes at 26 weeks, you give steroids, she doesn't deliver, now she's coming at 30 weeks. There are studies recommending repeat steroids like every month antenatally. So you can get a second course a month from the first one. And there are studies about giving higher doses for twins, triplets. So far is not strongly recommended. Now, conventional versus high frequency ventilation. When the high frequency or ventilator, sometimes called oscillator, came in the 90s, it was believed that it will be it will provide smooth and gentle ventilation, and that it will lower the rate of RDS or have better treatments and lower rate of long-term outcome. Because in the normal ventilation, the pressure goes up and down, too much, too little, and then that can cause trauma to the lungs. Versus in the high frequency, you just inflate the lung to the mean airway pressure, and then you vibrate around this mean airway pressure. So anyways, initial studies showed some hope for this, but later with the advent of a newer generation of mechanical ventilation, the synchronized machines, the machines with higher PEEP, this really downgraded any advantage to high frequency. So currently high frequency is not used as a primary mode of ventilation. It can be used as a rescue. Volume targeted ventilation. The new ventilators nowadays has a feature of giving fixed volume. So you want to give certain volume to 4 to 5 milliliter per kg. And then the machine, the ventilator, will give pressure just to achieve this volume. So if the lung really has lower, if the lung is stiff and needs higher pressure, let's say, it delivers the pressure. But after giving surfactants and the lung become compliant, you need less pressure. So the machine will cause so-called auto-wean. It gives less and less pressure as the lungs mechanics improve. In a Cochrane trial, so it has 20 trials together, over 1,000 infants, the volume targeted ventilation babies were more likely to extubate earlier, have less abnormality of the CO2, less complications like pneumothorax, IVH, and less PPD or death. So there's a lot of promise for this volume targeted ventilation. There are studies about the use of inhaled nitric oxide to lower or treat RDS, lower complications. So to make the long story short, it's not that classic way of treatment. Yes, it may have some advantage, but it's not standard of care. So if RDS is not treated properly, it can lead to the so-called bronchopulmonary dysplasia, which is chronic lung disease. That by itself has a long-term morbidity. This can be a lecture by itself, just kind of 2 slides about this. How do you define PPD?
If the babies are born less than 32 weeks of gestation and they need oxygen at 28 days of life, so we assess them at 36 weeks corrected gestation. So let's say a baby was born at 30 weeks gestation and needed oxygen for 28 days. Now 36 weeks corrected, you assess. If the baby breathing room air, it's mild PPD. Needing low rate of oxygen, it's moderate. High oxygen or mechanical ventilation or CPAP, it's severe PPD. The babies are more than 32 weeks of gestation, you assess them at 56 days of life with the same criteria. To prevent PPD, the way to treat or prevent by giving antenatal steroids, proper treatment of RDS, gentle ventilation, vitamin A, caffeine, prevent and treat infections, proper nutrition, avoid fluid overload, treat PDA, selective use of postnatal steroids, and maybe the use of inhaled nitric oxide. So in summary, RDS, a disease suspected in any premature infant with respiratory distress. RDS is caused primarily by surfactant deficiency in an immature lung. Surfactant deficiency causes alveolar collapse, leading to low lung compliance, VQ mismatch, hypoxemia, and maybe lung failure. Antenatal steroids can prevent or ameliorate RDS. CPAP is the primary treatment for RDS if it is applied early, properly, with the proper monitoring and maintenance. Surfactant and intratracheal intubation are necessary when CPAP fails, or maybe in the extremely premature infants. Earlier administration of surfactant produces better outcome. Vigilant monitoring before and after surfactant administration, and wean ventilation as early as possible. And this is the end of the lecture. I put some few questions. If we have time, we can go over this if you want. I'll give you the microphone for questions or comments.
يعطيك العافية حكيم.
هلا بيك، الله يسلمك.
دكتور، مشان السورفاكتانت يعني الآخر مدة ممكن نعطيها بعد بدء الأعراض بالRDS، شو هي ممكن نتوقع إنه تستفيد عليها؟
يعني anytime there is respiratory failure, you decide to intubate because of RDS, you give it. ما له وقت محدد.
يعني ما في ماكسيموم مثلا 8 اور او اكثر، 8 ساعات فما فوق؟
لا ما في بس هو عاده البيبيز declare themselves، يعني عاده مثل بيقولوا they'll go one way or another، يعني يبين عليهم. بس لا يعني ما في، جوابا لسؤالك ما في.
تمام.
طيب خلينا نعمل السيناريو تمام، وخلينا كله مع بعض وتجلس في اسئله ثانيه. ماشي، ما بعرف اذا بنقدر نعمل هيك مثل يعني ديسكشن ولا لا. ماشي، هناخذ 32 weeks gestation, male infant delivered by C-section, emergency C-section due to acute placental abruption. Apgar score 5 and 7 at 1 and 5 minutes. Baby had respiratory distress shortly after birth. What is the highest risk factor for respiratory distress syndrome? So out of these, which one makes the baby at higher risk for RDS? طيب انا يبدو بجوز حناخذ وقت اذا كان بدنا نسمع كثير ناس، فمعلش go through the answers. Either placental abruption or not given of not administration of steroids, C-section delivery, male sex. All of these are risk factors for RDS, but in reality prematurity carries the highest risk factors. So always when there is prematurity, keep in mind RDS, this is the highest risk factor. طيب, the baby is now 10 minutes old and having respiratory distress, nasal flaring. He's requiring 40% oxygen to achieve saturation of 93%. What is the best intervention? So this baby is in the labor ward, only 10 minutes old. So is it to admit to the ICU on nasal cannula and decide later about the plan? Start CPAP in the labor ward, then admit to the ICU and assess. Intubate, give surfactant, extubate, and apply CPAP. Intubate, give surfactant, and keep on the ventilator. Do not extubate. Admit to the ICU, do X-ray and gases. Intubate, but do not give surfactant. Admit to the ICU, do X-ray, gases, and only give surfactant if there is X-ray or gas suggestive RDS. So some units would do any of that, yani, but the trend nowadays is to do CPAP in the labor ward. So if CPAP is available in the labor ward is really how we start with, yani. But giving surfactant and extubating right away, maybe it was applied before, but not anymore. And intubation is really to be considered later. But the best answer would be CPAP in the labor ward, and admit the baby on CPAP. So the doctor has decided to start CPAP at 5 centimeter water, admit to the NICU for further management. 3 hours of life, the baby has mild respiratory distress. He's requiring FiO2 30%. Chest X-ray showing mild decrease in lung expansion and ground glass appearance. Blood gas, pH 7.25, PCO2 55, bicarb 22, basic cis -2. So what is your next action? So baby is still having a picture of RDS despite the CPAP, but not that sick yet. Is it continuous same management and monitoring? Is it same management and do X-ray every 6 hours to follow up on the X-ray and decide about surfactant? Is it to intubate, give surfactant now, intubate but don't give surfactant, wait until FiO2 is higher or mean airway pressure is high? Start non-invasive positive pressure ventilation. Now we didn't talk about this non-invasive positive pressure ventilation, which is basically through the CPAP, you're giving more like mechanical ventilation type of thing. So through the CPAP, you're giving high pressure, low pressure, and rate. So there are believers in this nowadays. So out of these, I guess I would choose the first one. So he's still reasonable, yeah, 30%. Okay, X-ray mild, RDS, gas is not bad. So you can really check, make sure the CPAP is functioning, make sure that there's no secretions, make sure there's no leak in the circuit, make sure the temperature, make sure, so the setup of the CPAP is appropriate, which is not simple, by the way. Yani you need to have some kind of skills with this. So make sure the CPAP is done, applied properly and maintained properly. Doing non-invasive, okay, some people would do this. I would not do it at this point. Now, follow up with X-ray should not be based on X-ray only. You should be doing a clinical assessment, the FiO2 demand, maybe blood gases. Shall you intubate right now? It's probably not yet. Okay, it's still somewhat contained, reasonable still. Intubate, but don't give surfactant. Same thing. Some people would do this. So again, this is not a question where there's straightforward answer. Okay, so maybe I would choose the first one. Okay, some people would like get ready to maybe intubate, give surfactant, and extubate. Okay, or do the LISA, less invasive. But I would say the majority would choose A. The doctor has decided to continue same management on CPAP, but 4 hours later, the baby started to have worsening respiratory distress, increase in the FiO2 50%. Blood gas is showing 7.19, PO2 42, PCO2 68, bicarb 21. So the chest X-ray showing worsening RDS. There's no pneumothorax. What is the next action? Increase CPAP to 7. This is a waste of time, I think. Give Ensure, intubate, surfactant, then extubate. Okay, that could be an option. Intubate, give surfactant, and use volume-targeted ventilation. This is another option. Intubate, don't give surfactant until FiO2 60%. I would not recommend this. Give surfactant through LISA mechanism, less invasive, and I think some people would do that. So again, I put this slide for discussion. Okay, so I'm done. I'm ready for your questions if you have any.
شكرا جزيلا دكتور ميسان، يعطيك العافيه.
الله يعافيك يا رب.
في عندي كويستشن صراحه بالنسبه لموضوع اللايزا اللي هو المشكله انه احيانا بتلاقي الطبيب ممكن يعمل انتوبيشن وبيقول لك ام شور انه التيوب اتسوكب حتى السي او 2 ديتكتور and you observe بتلاقي الكلرز not change والبيبي start to desat and to be bradycardia when they will discover that the tube is out. So I think it's possible also same can happen for the catheter. You think might it be in the trachea and maybe it will sludge out or to be out from the beginning, and you give that تعطي دوز كلياتها تبع السرفاكتنت في المريء بالفيجاس. فايش يعني ايش وات اتس جارانتي انه يكون فعلا في التريكيا؟ نحن بنعرف يعني السي او 2 ديتكتور اتس مانداتوري تو بي شور انه تيوب في شو اسمه، لكن كيف بده يتاكد الواحد صراحه؟ لانه مشكله كبيره يعني بتعرف، خصوصا بالنسبه للمناطق اللي التامين السرفاكتنت فيها صعب جدا، تحط الكاتيتر وتعطي الدوز كلياتها يطلع برات اللانج كلياتها.
هلا هو some would recommend leaving the laryngoscope, not removing the laryngoscope, leaving it in place and to make sure that really the tube is not dislodged. And I will give you my own attitude. Okay, يعني my colleagues, some of them are strong believer of this LISA. And personally, I don't see really big difference between LISA and the Ensure, so to speak. I would rather put an ET tube. I'm sure it's in, and give surfactant and do few baggings. But there are some, some famous figures. They talk about bagging only few seconds can cause the lung damage. I really don't see that in the real life. So again, some people recommending leaving the laryngoscope so that you make sure the surfactant tube is in. I think it's also traumatic to the airway. Personally, I think this is, we should wait before LISA becomes the standard of care. I think it should be used on, selective cases.
طيب في حدا من الأخوة عنده أي سؤال أي استفسار؟ أعتقد كان في سؤال يمكن على الشات، هو دكتور أحمد يوسف. What the recommendation of surfactant administration at full term?
You need to make sure that you're dealing with surfactant deficiency disease. Okay, this is full term babies. Think of other problems resulting in respiratory distress. Now, sometimes you see a big baby, 37-weeker to maternal diabetes, who did not receive steroids. Some of these babies have a true RDS. Okay, but giving surfactant for, let's say, TTN or somebody, I don't see that there's an indication for surfactant in full-term infants. When you see typical RDS in a full-term infant, this is the rare case of surfactant protein B deficiency. That's how we see it. And these are not, they don't respond to surfactant. They respond for a few hours just to deteriorate again. So again, the RDS is not a disease of full-term infants, but be aware of the late preterm. Again, 36, 37, maybe 38 weeks. Sometimes we see it with the complications, either asphyxia or maternal diabetes or that kind of thing. So if you have the history suggestive with the X-ray, okay, fine. In this case, you can consider.
هو قصد الدكتور أحمد مثلا الحالات الميكونيوم اسبيريشن سيندروم.
أيوة.
bleeding, sepsis، هيك قصده أعتقد.
أيوة طيب okay that's a good point. أنا أخطأت فيه. We do give it for meconium aspiration, but we wait until the baby is becoming sick. Many of these meconium, if you treat early, okay, you can prevent worsening of the symptoms. But if you see the baby requiring more FiO2, if you see more like lung collapses or lung fluffy infiltrates, whatever, yes, surfactant can be considered. There are studies supportive of the administration of surfactant in meconium or pneumonia. It's not strict like criteria, but overall, you try without. It's not something you give it early. You try to treat without surfactant, but you see the baby getting worse. Certainly, surfactant is one of the treatments for meconium aspiration, especially. Back to you.
السلام عليكم.
السلام.
يعطيكم العافية. شكرا دكتور ميسان، شكرا جزيلا على المحاضرة. الله يعطيك العافية. عندي سؤال لو سمحت، بالنسبة للميكونيوم اسبيريشن سيندروم أو حتى الكونجينيتال نيمونيا، لما نقرر نعطي سورفاكتنت، يعني في عندكم حالات when to repeat the other dose of surfactant؟ يعني نحن مثلا في ال RDS ممكن نعطي 3 جرعات أو حتى 4، اعتمادا مثلا على الاف اي 2 او كلينيكال اسسمنت. في حالات مثلا الميكونيوم اسبيريشن سيندروم، طفل لسه عم يحتاج هاي اف اي 2 هاي سيتنج، فينا ممكن يعني في دراسات او شيء ممكن تعطي فائده لاعطاء other او third dose of surfactant؟ وشكرا جزيلا.
العفو، الله يبارك فيك. احنا we give second dose. يعني if the demand is high we do give second dose. بس يعني after 2 doses I don't remember any case. We have a lot of meconium aspiration with PPHN sick babies يعني. بس once you give 1 maybe 2 doses خلاص يعني you're dealing with something different يعني at this point. We're dealing with the meconium, the VQ mismatch, the high pulmonary pressure. Then other treatments higher is what works, nitric oxide or high frequency. Yes, surfactant works, but surfactant doesn't cause dramatic improvement يعني. Beyond 2 doses I don't remember giving any baby more than 2 doses in our unit. ما بعرف إذا الدكتور عدنان عنده يعني بال up to date.
يعطيك العافيه دكتور ميسان. صراحه نحن it's very very rare to use السيرفاكتنت في الميكونيوم اسبيريشن سيندروم. و يعني ملاحظ كمان الاشخاص اللي بيستخدموه ممكن عندهم خبره اكثر في انه some babies you give them surfactant they will deteriorate حتى مع السيرفاكتنت، ما هو دائما انه بتحسن المريض. اعتقد المينلي باثولوجي في الميكونيوم هو البي بي اتش ان اكثر منه. ف most of them if you have nitric oxide and you started sometimes high frequency it can help also. Most of them it's improving with us يعني very rare to have a meconium severe تكون lung whitish كذا. That's time maybe you can think about surfactant. لكن most of them صراحة بيكون الشنتنج والمسماتشنج اعتقد هو السبب الاساسي، وقسم كبير منهم صراحه بتحسنوا على النيتريك اوكسايد اكثر من انه تعطيهم سيرفاكتنت. فنحن صراحه it's very rare to use it with the meconium.
فهي يعني different مثل بيقولوا ways of managing. For us we especially the first dose we give نحن. I'm thinking maybe the units that don't have nitric oxide يعني surfactant is what's available. And there are studies. I know there are studies supporting the use of surfactants. Not a lot of studies, not major studies, but there is some evidence for giving surfactants. But as you said, Dr. Adnan, it's not the primary surfactant deficiency disease.